So at the moment now, it's only coming out of that speaker. So to be honest, you can make really intense eyes with me if you do need to turn it down a little bit. But to be honest with you, I think that's bang on. Yeah.
Get some juice on it. If it's in there, that's it.
Yes. It's that one now, so they won't hear, will they?
No, that's right.
I'll put one here. Good morning, everybody. The next session will be starting on stage in just a moment. If you'd like to make your way to the seating area. Thank you.
just in case you were wondering why this man is standing up in front of the microphone, it's because I want to start the next session. Welcome to this panel discussion about creating a movement for health equity and what it means. We have a brilliant panel. Bola Owolabi, who's the head of equity, I think of it, but inequalities in NHS England. Kevin Fenton, who's president of the Faculty of Public Health and is head of public health in London, but also at the Office of Health Improvement and Disparities in Department of Health and Social Care. Pete Gladwell, and I'll get it wrong again, the Director of Social Impact Investment at Legal in General. And I should have said at the beginning that our health equity network is supported by Legal in General. And you may wonder, what are we doing in bed with some giant financial organization? We're all of us, most of us in the public sector, one way or another. What are we doing with this organization and accepting support from them? Well, I think it's actually highly relevant to action at local level. L&G approached us and said they wanted to know if what they did in their day job could improve health and reduce health inequalities. And we did a report that they sponsored, and they emphasized they didn't want it to be just for them, they wanted it to be for business. And we talked about better quality of work. Everybody employed should have a real living wage, goods and services, and being an anchor institution, having a positive impact on the community. So we're very grateful for this support from L&G, and we value the work that we are doing with them. That wasn't giving disproportionate background to Pete. It was just, I'd forgotten to mention L&G till now. So what does it mean to create a movement for health equity? I ended my remarks this morning by harking back to the launch of the World Health Organization Commission on Social Determinants of Health. When we launched the commission, I said, somewhat naively, that we wanted to create a social movement. Several years later, one of our colleagues, in fact from Barcelona, sidled up to me and said, Michael, there's a lot of experience with social movements. You don't just say it. People know what it's about. Well, like much else, I was pretty naive and wasn't quite sure what it meant. But I think we're doing it. And the question is, what is it and how do we foster it? The WHO Regional Office for Europe held a high-level meeting in Copenhagen a few months ago, and I got an invitation asking me to kick off the second day of the meeting. The Prime Minister of Iceland was kicking off the first day, kick off the second day of the meeting with an inspirational address from 9:05 to 9:10. So I said three things. Three challenges: intergenerational equity. We talk a lot about equity within the generations, differences in different parts of Birmingham and elsewhere, but equity between the generations, action on social determinants of health, and rediscovering public purpose, the common good. Let me touch briefly on those three. Surveys, and I'm an inveterate nerd, everything I say is always based on data. I'd be a terrible politician because I stick to the evidence all the time. Surveys in different countries. Ask people, do you think today's children will have a better life than you, about the same, or worse? A minority of today's a minority think that children will have a better life than them. Think back to your own parents. If we'd asked your parents that question, they would have said, our children will have a better life than us. And they were right. Don't want to go too closely into the demographic profile of the audience and how old your parents were when you were born, but they were right. If they went through the war, the immediate post-war generation, baby boomers, whatever, that's what we expect. But now, majority of, and they're right. If you look at social mobility, it's not getting better, it's getting worse. So what have we done? And it's not just the climate crisis, although it is the climate crisis, but it's social and economic inequalities that mean today's children will have a life that's either about the same or worse than their parents. Oh my gosh. Second big challenge, and it relates to the first. If we want to do something about that, we have to have action on the social determinants of health. And picking up the theme that I touched on in my few remarks this morning, very struck by Gary Gerstle, American historian. A recent book was called The Rise and Fall of Neoliberalism. His argument, evidence-based as a historian, was that Franklin Delano Roosevelt ushered in the New Deal in 1933, and it lasted till Reagan and Thatcher. Recognizing, and arguably, what FDR did, people said he was a traitor to his class because he was upper class, wealthy American, but he wasn't. He saved his class. He saved capitalism by recognizing that you had to tame its excesses, and government action, social action, was vital. Gerstle points out that Eisenhower, President Eisenhower, was essentially a New Deal Republican. I think you could probably say, although he'd turn in his grave if I said it, that Harold Macmillan was a New Deal Tory. So it wasn't conventional right and left. This was the accepted idea. You're a bit more right, a bit more left, but it was an accepted idea that we needed a mix of social and public action and private enterprise. And that went out the window. And we ushered in the age of neoliberalism. Well, I think most people would say that's hit the buffers. And that was the thrust of Gary Gerstle's book, The Rise and Fall of Neoliberalism. And that means rediscovering public purpose, recognizing there's such a thing as the common good. And that, colleagues, is what we are all engaged in, working for the public good. We're not doing it for private profit. Yeah, we're all selfish in some measure, but our rewards come from working for the public good. A day well spent is a day making progress, not a day where we cheated somebody else out of their profit or whatever. It's a day advancing progress, whether we're in the private sector, in the voluntary sector, in local government, in health and social care. And that's the social movement I think we are trying to create. Health equity, yes, but it's actually equity in society, a society that functions for all of us. And those of us who come from the health sector but recognize the vital importance of social determinants of health are actually working to try and recreate fairer societies. And that, I think, is what our social movement should be about. We cannot do it alone. I get asked by well-meaning GPs. Bola's background is primary care. I get asked by well-meaning, but what can I do? And my answer is you can't do it alone. That whether it was the women's movement, suffragettes, universal suffrage, improved working conditions, civil rights, these are social movements that lead to real advances in society. We want a social movement for greater equity in the conditions that will lead to better health for all. And we can't do it alone, which is why we've convened this network, so that we can learn from each other's experience, we can be inspired by what others are doing, and, dare I say it, the nerd in me, we can figure out what works and what doesn't, and not waste time doing things that are useless, and learn from each other on what works. So my view of this social movement is this health equity network will play a vital role. We want it to spread all around the United Kingdom, and we want it to be a model for other countries in the world. Welcome to our social movement. And each of the speakers will have between 5 and 10 minutes. And then we've got people online who may have questions. And please be thinking of your questions or comments from the audience. So, Bola.
And can I just say a huge thank you again to Sir Michael for leading the charge way before I was born, actually. I think it's worth saying. And as the King's Fund have said to us, that to move the dial on health inequalities, we need endurance. And I just want to say thank you for being the epitome of endurance in this space. So then, standing on the shoulder of that giant, I think I'm going to come from the perspective then of the hope that we have as a movement to make a difference. So many of you will be familiar with the working definition, certainly from an NHS England point of view, that health inequalities are avoidable and they are unfair. And I'm picking up those two words really because it means that it is a soluble challenge and that we can take tractable action. So I'm framing and anchoring my talk on the basis of the fact that it doesn't have to be like this. We can avoid it. and it is unfair. And I suspect that everyone in this audience is here because we have an innate sense of justice and fairness. And that is my hope in terms of what we can do given that. But of course, health inequalities are, as many people have said, complex. And oftentimes that has been the shorthand for, and therefore it's too difficult to do anything about. But I hope that this would be a network that chooses to focus on its own spheres of influence, rather than dwelling perpetually on its spheres of concern. And we know what those concerns are, and they're real. But I think we can lead the way in starting the conversation about, as Michael was saying, so what works? And so I'm going to talk about the system response that we need, because no single sector, no single individual or organization has the answers. The answers lie between us. And that's why a movement is necessarily the response. It is true that the wider determinants of health, education, housing, household income, educational attainment, those big societal drivers, it's true that they drive, as we've been told, 70 to 80% of health inequalities. But it's important to recognize that the 20 to 30% that is left, which is a function of health care inequalities in people's ability to access services, the quality of their experience, and therefore their outcomes, the 20 to 30% of a big number is a big number. And therefore, it's really important that we talk about what is the contribution of the healthcare system to the wider system response to health inequalities. And I think the healthcare system can maybe think about its contribution, and it is a contribution, across 4 dimensions. There's something about the role of the NHS as a commissioner and a provider of services, and therefore the sphere of influence we have to commission, to procure, to contract in such a way that we reach those at the margins of our community. Some of you may have seen the report from South Banks University published just this morning, talking about one size does not fit all, and the necessity of being mindful of those who suffer socioeconomic disadvantage, of those for whom English is not their first language, of children and young people, of those with learning disability or autism, people with serious mental illness, our coastal communities, people experiencing homelessness, essentially those at the peripheries. And so our first role as a healthcare system is as a commissioner and a provider of services, and inherent within that, the levers we can pull to make sure that they're not left behind. Secondly, the role of the NHS as an anchor institution. So the decisions we make in terms of procurement and using that social value element of our procurement framework, how we choose to use our estate. You may have seen the 10 building blocks that we published a few months ago about how we can use our estate, the NHS as the largest owner of estate in this country after the Ministry of Defense. We can leverage so much of that, whether it's what Dr. Hussein was doing in London, opening up the surgery as a place of warmth for people in deep, deep winter who couldn't heat their own homes. We can use our estate to reach those at the margins. Or indeed our role as an anchor institution in terms of the employment practices that we follow. I think about Mid and South Essex NHS Trust, working with their further education colleges, providing apprenticeships for kids in the 6th form with learning disability, and training them for a year as useful and important part of the NHS workforce. we can leverage our role as an anchor institution, or the role of the NHS as a key partner within the integrated care system, where we come to the table with our voluntary sector partners, with our community providers, with business and industry, with the local authorities and our councils, the contribution we can make as a part of the integrated care system to begin to make a real difference in people's lives. So Birmingham Hospital, recognizing that young people experiencing homelessness have a lot to contribute. So they repurposed their old nursing quarters built in the 50s. They repurposed them and gave housing to these young people. And they called it a no-benefit intervention because they sorted out the housing, they gave them jobs. Tackling health inequalities is a win-win. When we tackle health inequalities, we deal with our own workforce issues, as well as making it better for the individual and the community. Or we think about Birmingham Children and Women's Trust. They looked at the rates of children not coming for their outpatients appointments, and it's children from households on 0-hour contract, those who can't afford the transportation, those for whom English is not their first language. They didn't simply admire the problem or describe it. They decided to do something. They supported with transport costs. And in 9 months, they reduced the rates of was not brought for these children by 50%, improving their productivity and improving access for those who otherwise will be left behind. And finally, the role of the NHS as an employer. The 1.5 million people who work in the NHS are a microcosm of our wider society. And in addressing their health inequalities, we gain the credibility and the legitimacy to address the health inequalities affecting the rest of the population. And so my call to us as a movement is to pivot from simply developing policy endlessly and getting into the space of moving policy into practice. And for us to be the movement that translates analysis into action. And the group of people who refuse to be comfortable with the rhetoric, but we can tell a cogent, coherent, and measurable story of how that rhetoric is translating into meaningful action in the lives of those who are not simply the data, but they are the real people who experience the knife edge of health inequalities. Let's focus on those spheres of influence and make a difference. Thank you.
One of the things that characterizes our budding movement for health equity is that we all become friends. And I feel that Bola has become a friend, and I especially feel that our next speaker, Kevin Fenton, has become a friend. And I think it's something about the spirit of what we're doing and the feeling of working together. And I almost forgot to say how privileged I feel that our panel members have come to Birmingham today to join with us. So Kevin, please.
Michael, thank you so much for the invitation to be here with you all today. Hi, everyone. It's such a pleasure to be here, and it's so exciting to be here because what's bringing us here together is a shared vision, it's a shared commitment, and it is a desire for action on health inequalities. I'm going to take a slightly different perspective in my words today because I'm going to talk about movements, the science behind movements, And I've been privileged as a public health practitioner to be behind quite a number of movements during my time, whether it is my early work on HIV prevention and really leading some of the efforts here in the United Kingdom and in the US around a better response to HIV. Some of you may know me from my work in Public Health England when I led on national NCD prevention programs, so the sugar levy, promoting physical activity, promoting public mental health. And my current role as the Regional Director for London is where we're starting a new movement on equity. And I wanted to share with you 3 key lessons that I've learned about movements and the power of movements. So the first of the lessons is our narrative. What is our story? How do we tell that story? And how do we bring others together around that story? And that narrative is important because politicians and policymakers don't speak in p-values or odd ratios. They speak in narrative. Now, I became a physician and I didn't want to become a doctor when I was growing up, right? I wanted to be a pilot. I wanted to fly around the world, see the world. But I will never remember 1981 when I was watching TV and those first reports of the first cases of gay men who were in New York and San Francisco with an unknown disease, who were first being featured. And the fear and the stigma and the hate and the emergence of inequalities that began at that time, I will never ever forget that. That changed my life course. It meant that I chose to do medicine because I want to be part of playing my role in ending this pandemic. And over the last 30 years, the injustices uncovered by the HIV epidemic have been a key part of ensuring that my role is not only in reducing HIV, but tackling the enduring inequalities which are at the core of driving HIV transmission. That's my story, and that's why I stand here before you today. Each of you has your story of why you're here. How powerful is that story when you tell it? And it's important that we're able to call upon that story because it inspires us, it drives us, it brings others to us. And that power of narrative is key for this movement. Now, the third part of narrative is understanding the power of now and recognizing that every moment is a chance for us to use our stories and use our lessons and use our experiences to drive forward on health equity. We've just gone through the COVID pandemic where the power of inequalities were laid bare and everyone in society knew what inequalities were because it was unfolding before us on a daily basis. Using the power of now and using the power of narrative is an important way of saying to people, inequalities aren't theoretical. They're not airy-fairy. They're not motherhood and apple pie. They kill us. They prevent us from having a good life. They prevent us from being our best selves. And they prevent us and hold the society back in terms of our productivity and what we're able to achieve. So, getting our narrative right is the first thing that movements need to do. The second thing that movements need to do is to organize for success. Now, as you spend your day here today, ask yourselves, are you organized to make a difference on health equity where you are today? What is the governance like? Do you have the right boards? Do you have the right vision, objectives? Do you have the funding to drive forward on inequalities? Do you have the right people around the table? Are you engaging communities? Are you holding leaders to account? And are you making your data transparent and accessible to those who need it to be able to make better decisions? We can talk about movements, but if we don't have a narrative and if we're not organized, we'll get nowhere. Look at what the HIV community has done over the past 40 years. They have had a narrative, we've organized, and we're driving forward on reducing HIV incidents. Look at what we've done on reducing tobacco. They have a narrative, they've been organized, and engaged leaders. Organization is going to be the second lesson that I've learned about driving movements. Now, in the final minute, I'm going to share with you the last lesson, which is so critical in movements. And this is leadership. And by leadership, I don't mean political leadership. I don't mean, somebody else. I'm meaning you. Because you are all leaders. You are all leaders of teams, leaders of selves, leaders of your family, leaders of your community. You are leaders. And I need you to find your voice, to find your narrative, and to lead and organize, and to advocate for leadership for equity. And as you participate today, and as you think about your actions as you leave this room, think about what you will do as a leader for equity. Make a commitment to start this movement. Think about the leaders that you're interfacing with, whether it is your local councillor, whether it is your local MP, whether it is the head of your ICS, whether it is the GP in your PCN, whether it is your local director of public health, and there are many of you in the room. Ask yourselves, what am I going to do as a leader, and how do I interface with leaders for this movement to succeed? So colleagues, I wanted to take a slightly different view this morning about the power of movements, how movements are created, and why narrative, organization, and leadership are key. Thank you.
Why did I not meet you 15 years ago? That was terrific. And I finished when I talked about the three things. I talked about public purpose and rediscovering the common good. In fact, the last time Pete and I were together was a week ago, 10 days ago, at an event organized by Public Practice, which is trying to bring architects and planners back into the public sector, saying it all got hollowed out. Let's bring them back in because they have an important public role to play. And Pete and I were both speaking at this meeting. So when I talked about becoming friends in this movement, I include Pete Gladwell in that. Pete.
Thank you so much for that introduction. I've made it as a friend of Sir Michael Marmot, so my job's done here now. But no, it's just absolutely fantastic to be here and see such a great collection of people. I just want to give you a heartfelt thanks for making the effort to come here today. When we were first talking to Sir Michael about, and Jessica, who's also here somewhere and deserves a lot of credit for making this happen, about what this could look like, I had this picture in my mind of people coming together from all different sectors and all across the UK and different regions to really focus on addressing the injustice of health inequality and health equity. And that picture kind of in my mind as we took this through the Board of Legal and General and the various steps we had to do to make this, to play our role in making this a reality. And then just seeing the reality in front of me today is really exciting. So thank you for being a part of it. It's particularly great for me to see people from the voluntary sector here as well. Before this job, I was a youth worker in Oxfordshire for many years. So I've long been, that kind of voluntary sector has always been a really important part of my life and kind of set the backdrop for the role I'm doing now at L&G. So it's just great. Just want to give a shout out particularly to those people who are working for the charities and voluntary sectors here, as well as public sector and business. So you've got L&G obviously sat here in the middle of this and delighted to be involved. And I thought it was probably worth just giving you an insight into how we've ended up being involved, in case that's helpful for thinking about how business comes into this movement and plays its role in this movement and what might motivate businesses. So I think Sir Michael knows this, but he mentioned there was an email, which I was the person who sent the cold email to Sir Michael going, hello, you don't know me, but could we talk about business and health equity? But the reason that email came about is because a couple of the prior weekends, I think I've admitted this story to you, the CEO of Legal & General and I and another colleague were WhatsApping each other videos of Sir Michael speaking at different events. And we were all fascinated by this concept and actually quite worked up by the issues, the social issues that Sir Michael was addressing, and kind of having a bit of a discussion on WhatsApp as to what we could do as a business to tackle this. And one of us, I can't remember which one, had the bright idea of just saying, well, let's just email him and see if he's up for a conversation about it. So, my point in saying that is there are actually quite a lot of people in business, and as I say, this is the CEO of L&G, the FTSE 100 group, who was sharing these videos on WhatsApp with me, who really do care about this issue. And I'm sure we're not the only company for whom this is a really important point of social justice and a really important topic that we individually care about. And one of the things I think I've learned as I've worked for moved from being a youth worker in Oxfordshire to working for a large corporate, is actually if you get enough people together who individually care about an issue, then it becomes a corporate issue. It's just about assembling that coalition within a corporate of the individuals who care, and it can actually move on the agenda from something that's personal to something that's corporate. So, I mean, the number one point for me in just trying to think about how we get business involved in this is that plea that please don't assume that people in business don't care, or industry don't care about this. There are people who go into business looking for opportunities to change the world through their day job, through the way that they work. There's several of them who work for L&G. People here from L&G are not here because I told them to come here. They came here voluntarily because they really care about that as well. And some of them because they wanted to meet Sir Michael. But anyway, that shows they care about it. So anyway, so my point being that you please don't underestimate the fact that just because people work for a business or a corporation or a financial institution, this isn't something that's important to them. And why do we care about this? What role do we see business being able to take? And this is really where the work we've done with Sir Michael and Jessica has informed our thinking. So yes, we can give money charitably, and that's an important part of what business does and should do. But for me personally, one of the things I care quite passionately about is business moving away from this kind of old school concept of CSR, where business might make some money and do all kinds of bad things, but don't worry, I've given a check to the local primary school, so it's kind of okay. For me, that is the last thing this is about, and the last thing that business should be giving money to charity, but it's about so much more than that. And for business to step up and fulfill its role in this movement, it needs to be about so much more than that. CSR for us is about our corporate social role, the role that Legal & General and other companies play in society and should step up to play in society. So it's a very different concept of the word, the CSR. And just to be really clear, this isn't about business replacing the need for a strong public sector. It's not about business replacing the need for a really strong and vibrant voluntary sector. It's not about business lobbying to pay less tax. Actually, paying a fair tax is an important part of our social role. But it's about us stepping up to see what good we can do and how we can tackle some of these issues and agendas alongside the public sector and voluntary sector as well. So the report that Sir Michael and the team pulled together, we were kind enough to give us a chance to put a bit of input as there to kind of bring our perspective from the coalface of business, as it were, focuses on 3 ways that business can really participate and be involved in this movement. One is the way we treat our employees, providing good work and good pay, and we've been doing a lot of work since that report with Sir Michael and the Centre for Progressive Change about making sure everyone in Legal & General's employment and people who work for Legal & General, including the many shopping centres we own and the many security guards who work in offices, are paid a fair wage, including sick pay and really important concepts like that. The second one is the products and services that business creates, and that encompasses everything from housing to food to financial products. The more you think about these things, the more you realize the role that business plays, for better or for worse, if business isn't brought into this movement, in the provision of goods and services that millions, billions of people around the world consume. And the third one is the role of influencing. Some of our institutions, and L&G to a certain extent has this, are anchor institutions within the country. And so the influence we bring to bear, whether it's as a major shareholder of most of the companies in the FTSE 100, or the conversations we have with government, and the influence we can, again, bring for better or for worse, is a really important point where contribution that business can make to this movement. So those three scopes are all ones that I would, I suppose, encourage you to encourage business locally to step up and adopt and consider. As for L&G and taking this forward, we're determined to continue to support the growth of this network. This is a commitment for us, and we're really excited, as I say, as to where we've got to already. But we do really need your help in this, and I just want to end with a plea, I suppose, really, to see the good in business and the potential that business can bring to this movement, to see the influence and the impact that it can have, and then draw business and look for opportunities to engage with people in business to bring them into this movement as well. Thank you for inviting us to be here, and all the best. Thank you.
Thank you to our brilliant panelists. Please, it's your turn now. Questions, comments, provocations for the panel. Yes, please. There's a microphone.
Thank you very much. Thank you, Michael. My name's Dan. I'm a Deputy Director at the Royal College of Physicians. I work in policy and comms. Hello. I'm going to talk about something I wouldn't usually bring up in my professional life, but I've got the benefit of I'm actually leaving my job by the end of the year, so I feel a bit freer. I spend a lot of my time advising people that I work for not to talk about politics or get involved in politics as politics. Think about the issue, think about the people, work to that person. What are they trying to achieve, and how can they help you achieve what you want to achieve? But at the Royal College of Physicians, as you know, Michael, we've set up an advisory group that you've kindly advised, and we set up the Inequalities in Health Alliance, bringing together now 250 organisations, all the Royal Colleges, big charities, small charities, local organisations, a couple of some NHS trusts and a couple of local authorities as well. And we've campaigned for something very simple to the government, to put in place a strategy to reduce health inequality. And as you have found, they have just ignored us, pretty much. And yeah, we've argued it on the basis of it's about the health of the nation, it's about the health of the economy. But as I say, it's fallen on deaf ears. But we look at what the Labour Party is talking about in its health mission, and it all looks very familiar in terms of what we've been calling for. So I just wonder if anybody on the panel, feels there is a place for this network, given that we'll be having a general election in the next year and a half, to be a bit more political. Because I think we all know that if there is a change in government, there will be a change on this agenda.
Thank you. Well, I'm not going to leave Pete out, but let's start with Bola and Kevin, because you work for public sector organisations. You report maybe one or two steps to politicians, to ministers. The NHS England is, in theory, more independent, but in practice, ministers are involved. How do we do this work either without getting overtly political or, as you're suggesting, getting more overtly political? What does it mean in your role?
I'll leave politics to the politicians. But, you know, it goes back to what I was saying earlier on. Great to see you, Dan. I do a lot of work with the Royal College. It's back to the spheres of influence question. So in my role at NHS England, we set about setting out what are the priorities, what is the mechanism for action, and how do we put tangible support around people, whether that is in terms of funding or creating the governance structures, as Kevin was talking about, and focusing all our attention on that. And it's only now that we are writing all of that work up into what we will call a strategy. I tell that story to make a point that we can proceed with the things that we can do, because actually the things that we can do, the summation of them will inform strategy at the right point in time. So I don't think anyone in this room needs permission to take action on health inequalities. You know, as Kevin was saying, every single person in this room is a leader in some sphere or the other. And my call to us as a network would be maximize that role as a leader in whatever capacity you happen to find yourself. And if national strategy catches up, excellent. If it never does, we proceed regardless.
Said that everyone should be a leader, but you also talked about engaging the political leaders. So how do you respond to Dan's provocation?
So thank you. Yeah, I'm speaking as a public health practitioner, public health professional, and public health is political. You know, whether we're working with local councillors, I have the privilege of being the Mayor of London's statutory health advisor. We have to brief ministers, we have to prepare policy papers for ministers. We are constantly engaging with political colleagues. And there are a couple of lessons which I think are really important for us to do it effectively. So number one is understanding that we're public health people and professionals, we're not politicians. So don't try to play the political game. Understand our unique selling point, understand our spheres of influence and our spheres of competence, and engage with our political colleagues from that place. The moment you try to get into that political space, that's when we run into problems. That's when you have issues of trust, when you have issues of being labeled, being out of the room, and not being able to influence political decisions. So understand your sphere of competence, where you're going to have your impact, and what your narrative is key. Second, because politics occurs at different levels in society and at different phases, it's amazing what you're able to achieve, even when one part of the system seems to be fighting against what you're wanting to achieve. So my second lesson is understanding and meeting politicians where they're at, and then leveraging whatever opportunity you have to push forward on the agenda. So I've worked in the US with the Bush administration at a time when their HIV policy was abstinence until marriage. Now you can imagine, how do you do HIV prevention if that is the narrative that you're working on? But we're able to find common ground with them as politicians and to move forward on some really important programs, even in what would be perceived as a hostile environment. And then more importantly, as you went more and more local and dealt with local politicians, you had more leeway to push on issues of equity, innovation, new ways of engaging communities and mobilizing, because local politicians get it, because they're interfacing with their communities more. So the second is meeting politicians where they're at. And then finally, I always say this to my team: be prepared, be ready. have your data, have your policies, have your strategy, have your asks ready, because you never know when that politician, that councillor is going to say, listen, I need something shiny and new. I need to announce something next week. What do you have? And then you move quickly. You look at what's happened in the last few weeks, from the focus on youth vaping to yesterday's announcement about creating a smoke-free generation, to the women's health strategy, to the HIV action plan. Even when you think you're working in an environment where you couldn't move forward, you often can. Thanks.
We've got two there. So,
thanks. My question's about impact of social movements. So we're trying to build a social movement around inequalities in Bradford. And one of the questions that we often get is, how are you going to know you've made any difference? As if there is almost going to be like an NHS monitoring system, and this is completely different. So that's my question, just some advice to the panel, is about how would you measure impact of a social movement for health equity?
and we have the next one too?
Thank you. Peter Lacey. Movements in terms of a narrative, a organising and a leadership, at a local level, all three of those are very vulnerable. Narratives can be counter-narratives. Organisation is a skill that might be lacking. Leaders are vulnerable at a local level. So my question is, how can a national movement work from the bottom up? Because that's where change will happen.
And then we had two here.
Thank you. So good quality data is key, reducing health inequalities, and especially when we want to reach to the people who need most health and care. But the problem currently is the data recording, especially ethnicity data recording is a big gap. And we saw in pandemic, we were still using 2011 census data, we were decision based. And it's been inconsistent and it's not timely. So what can we do about the data recording, especially on ethnicity data? Thank you.
Hello, Andrew Fenton from NHS South Central and West. Integrated care systems have got big challenges, of course, around operational and financial pressures, but they've got also a lot of ambition around their impact on population health and inequalities. And their strategies are showing quite a lot of very diverse and powerful programs. But I wonder if you think they've got enough focus on specifically equity and experience of healthcare services. So there's a lot around reducing health inequalities with partners, particularly across with public health and the VCSE. But I wonder if there is enough specific focus around equity and experience of care.
Great, terrific. Bola, let me start with the last one. And related to it, let me just add a little bit to it. There's potentially a trade-off between efficiency and equity. Got a limited amount of money, get the best amount you can of output for that amount of money. That might mean spending on the middle classes. Don't spend on the poor, because we know the response to treatment to cancer, you get better survival if you spend it on people who already have other positive attributes. So that suggests a collision between equity and efficiency. Using the money in the most efficient way possible might mean, well, never mind people in the gutter, they're too hard to treat, just let them rot. I'm overstating it, but it's picking up on this point. How do you, given all the pressure to be efficient, how do you bring the equity argument in?
So it's a really important question. And for me, the thing that is great is when you look at the 42 integrated care systems, their 5-year strategies, their joint forward plans. Perhaps for the first time ever, the strength of the narrative and the content about health inequalities is so strong. And that is what movements achieve. I don't think that 3 years ago or more, we will be in a position where there is that strength of narrative on health inequalities. So I just want to first of all state that we are making progress. But your point, though, that what is contained can often talk about what we do in partnership on the wider determinants. That's why I was making the point earlier that we need to talk about health care inequalities so that we as the NHS take our responsibility for people's ability to access our services and therefore the quality of their experience. Because if we focus just on the social determinants, it skews the weight of responsibility onto the local authority and the voluntary sector and other partners within the ICS, and makes it likely that we will continue to be light on narrative about healthcare inequalities. And that's why I call it out at every opportunity, so that we don't absolve ourselves of that particular responsibility. I think back to your point, Michael. So my narrative is that tackling health inequalities is a win-win. And I've given a number of examples of where that is the case, using the examples of outpatients, DNA appointments, and so on. And we see it playing out actually in so many other areas, long-term conditions. If we can pick them up earlier in people from our most socially disadvantaged communities, then we have greater opportunity to intervene. And only yesterday, I was looking at an excellent example from Hertsmere, where the Borough Council, working with the primary care networks, looked at their cervical cancer screening rates. And guess who isn't coming forward to have their cervical screens done? The most socioeconomically disadvantaged. And what was really interesting, I'm just going to quote a few data points to make the point that tackling health inequalities is win-win. They sent out over 7,000 invitations. They had over 4,000 non-responders. They decided to look at the non-responders' data and cut it by what we call Core 20+. And they focused on that subset of the data. They actually managed to get about 1,000 more people to come forward for their screening. Over half of that 1,000 were first-time responders. 150 of those had abnormal smears. Abnormal smears that we can now do something about, that doesn't involve chemotherapy and radiotherapy and multiple hospital attendances and. Never mind the benefit to the individual. So actually, addressing health care inequalities is a win-win. And that's why those plans need to not just talk about what we're going to do with councils on the wider determinants, but absolutely spell out what are we going to do for those at the margins in relation to healthcare inequalities would be my view.
Kevin, I'm going to come to you in a moment about impact, but let me turn to Pete. The question that was asked about vulnerability at local level, we want a national movement. You work a lot with local areas, you know, mayors and local government. How do you stop this national movement from being very vulnerable at local level? And then the other question I wanted to ask you relates to Dan's question about politics. You'll remember that we were coming back on a train, and I asked Nigel Wilson, the CEO of Legal & General, is Legal & General the kind of corporation it is because you're the chief executive? Or are you the chief executive because of the kind of corporation it is? And if you get a different leader, could that social movement within the corporation change overnight? So 2 questions.
I'm about to find out the answer to that when our new CEO arrives in January. But so far, he's shown every sign of being as passionate about this as Sir Nigel is. Yeah, I mean, you're absolutely right. So we wanted to be involved in this network because we thoroughly believe, in case it's not obvious enough, that the answers to a lot of this are place-based and local. But at the same time, even if you have platoons of people doing fantastic work locally, if they're all having a bilateral conversation with you and your team, it won't be as powerful as if they can come together and learn from each other and inspire each other and encourage each other. And all of those things were literally, for me, one of the key rationales of bringing this together. So in case it's not obvious enough, for me, it's incredibly important that this network is owned by those of you who are really making an impact. And I am all ears, and I'm sure the team are as well, Alan and the team are all ears in terms of how we can support you and make sure this network is delivering what you need to continue the great stuff you're doing up and down the country. For me, we'll have failed if we're not supporting you and enabling kind of great examples of success to come forward. Do you mind if I kind of drift on to the impact one? Because I think that's a really important part of this.
Okay,
So
sure.
just really briefly, yeah. So because for me, those, and it comes to the political point as well, I think, we have various conversations with government and other political parties. We've always found that a kind of a quiet but persuasive approach really does make great progress. And I think the power here is where we can give really, really clear local examples like Bola was alluding to of where measures have made a difference. But the power is also, I think, in the combination of sectors in this room. If the NHS goes in to see the Treasury, a certain guard will come down. If we go in to see the Treasury, a certain guard comes down. I think the power of the many sectors in this room coming together and saying, here's some things we together can believe will really make an impact locally, will have real power. And we're up for discussing how we could best achieve that with government in future as well, because I think it's a really important function of what we could do together. And bringing out those local success stories is going to be really key to that.
So, Kevin, there were two linked questions. One is, how do we assess the impact of a social movement? And I think the implication was there should be some kind of monitoring framework. And the second question was about availability and quality of data.
Thank you, Michael, and thanks to the question. So I'm hoping what I'm getting across is that movements may seem spontaneous and may seem organic and may seem sort of ad hoc, but actually successful movements are planned, they're deliberate, they're focused, and that allows those movements to move forward in the right direction and to build coalitions of the willing and to grow and to be sustainable both across generations, for example, what we're seeing with HIV, but also to ensure that you are continuing to generate impact. So I'm going to use two examples of movements that I'm currently involved in to show you some of that in action. The first is our journey to end HIV transmission in England by 2030. So we are on track to reduce HIV incidence in England by 2030. That's 7 years. And this is a combination of better testing, pre-exposure prophylaxis, amazing treatment. For that movement, we've articulated core objectives which are shared whether you're working national, regional, locally, or in the community. We're going to end new HIV diagnoses. We're going to end deaths from HIV and AIDS. We're going to end HIV stigma. And we're going to fundamentally change how new technologies are integrated into our work. Those 4 objectives become the mantra for wherever you are in the system working on HIV. And then those 4 objectives to the question on data allows us to identify the core indicators and metrics so that we can measure our progress on each of those 4 things. So we know exactly what's happening with HIV incidents, exactly what's happening with deaths. We've now commissioned a new HIV stigma survey to measure that, and we're reporting this on a regular basis. The second movement that I'm involved with is implementing an anti-racism approach for the health and care system in London. First time it's been done in the city, and it comes off of the back of our devastating experience of COVID-19 and a commitment of health and care and local authority and community leaders to ensure London has more resilience moving forward. For that movement, we've developed a strategy. We have our objectives. We're now developing the data that allows us to both measure the lived experience of racism, racism within our staff, the experiences and the impacts of the interventions that we're putting in place. And we're also combining that with qualitative data, so the lived experiences of Londoners and staff can be measured. So I'll end there, because what I want to do is to say what you're seeing and what we're creating has to be deliberate. It has to be mindful. It has to be organized. And we can do this. Thanks, Michael.
Thank you. That's a much better answer than I would have given. I would have said, we've developed a monitoring framework. Go and have a look. But I like your answer much better than mine. And it is, guess what? You know, I'm just thinking to myself as Kevin was saying this, being clear about what it is we're trying to achieve in the way you just laid out with the two examples, and then gathering the data to assess it. Now, for what it's worth, I'm a little bit embarrassed about this Marmot business, but Coventry has a Marmot instrument. I'd say I'm a bit embarrassed. A councillor in Manchester said to me, "Oh, you're Marmot. I didn't realize Marmot was a person." We talk about implementing Marmot, you know. So Coventry, you know, you can look online. In our work with Greater Manchester, we worked with colleagues to develop 24 indicators. Regrettably, in Cheshire and Merseyside, it was 22, so it wasn't exactly the same, but it was pretty close. And I think one of the things coming out of the network can be adopting a relatively, not a diktat from the centre, but a relatively common measuring framework so we can see what's happening. I mean, I get asked, well, okay, Coventry was the first Marmot city. Did it work? Well, the honest answer is it wasn't set up as an experiment. I mean, in one sense it worked because Coventry's so enthusiastic and they've got people all the way in every sector wanting to continue. But the things we can cite is the proportion of children age 5 with a good level of development went up. The proportion of 18 to 24-year-olds not in employment, education or training went down. The proportion of employed people earning a real living wage went up. Now, I don't know the counterfactual. I don't know what would have happened had they not done that. So I'm being quite honest about we don't have a very good evaluation. But that's part of what we'd like to come out of the network, so we can actually say with a bit more confidence, not just we can see that there's real progress, and it's what Kevin said, but we've got indicators to assess how well we're doing. Good intentions are great, but they're not enough. We need to know that things are working. What a wonderful panel. Thank you very much indeed. And we break for lunch, and you'll tell us what happens after that.
Thank you very much, Michael, and the panel. Yes, we break for lunch now. You have until 1:40 when I will be again shepherding you into this room to hear Justin Varney and start off the afternoon session. And then after that, we'll hear from Jessica.